కొన్నిసార్లు ట్రాఫిక్ లో డిలే అయిపోతుంటే మోహన్ సార్ ఈ లోపల ఆడేసుకుంటాను నన్ను, నువ్వు ఉండట్లేదు క్లాస్ స్టార్టింగ్ లోని. అందుకే ఇంట్లో కూర్చున్నాను, ఒక 10 నిమిషాలు ఆగి స్టార్ట్ అవుతామని.
మేము కూడా అంతే, ఒక 10 minutes లో స్టార్ట్ అయిపోతాం.
గుడ్ మార్నింగ్ సార్.
శ్రీకాంత్ స్టార్ట్ చేద్దామా?
సార్
గుడ్ మార్నింగ్ సార్.
రిఫ్లెక్షన్ ఆ రోజు అడిగాను సార్, మళ్ళీ ప్రెజెంట్ చేయమని. సో ప్రజల కోరిక మేరకు శేఖర్ టేకింగ్ అప్ ద క్లాస్.
ఒప్పుకున్నాడా?
అంటే ఆ రోజు ర్యాగింగ్ కొంచెం తక్కువైందని వాళ్ళు మళ్ళీ ప్రెజెంట్ చేస్తారు. శేఖర్ వాయిస్ బ్రేక్ అవుతుంది, స్క్రీన్ కూడా నెట్ చూసుకోవచ్చు.
శేఖర్ నెట్ బాగానే ఉందా?
20 minutes. సార్ రావట్లేదా?
మాకు బాగలేదు.
బ్రేక్స్ వస్తుంది బాగా వాయిస్.
సార్ వినిపిస్తుందా? మీ ఆడబుల్ వాయిస్ బ్రేక్ వస్తుందా? ఒక నిమిషం, ఐ చేంజ్ మై పొజిషన్. ఇప్పుడు వినిపిస్తుందా?
ఇప్పుడు ఓకే.
బెటర్.
Shall we start, madam?
Yes, Shekhar.
So today, this is a second class regarding this. This is a repeat class, which was actually presented at the recently concluded CAPS on liver and kidney. This is an interesting topic and a remote topic to most of us. Anesthesia management in a post-transplant patient posted for non-transplant surgery. As I said in the previous class also, we may not be a transplant anesthesiologist by qualification, but we might have to deal with a lot of transplant patients coming for non-transplant surgery in your future. So we have to know what are the implications of a transplanted patient, and what are the drug interactions, what are the specific considerations that we have to take in these patients particularly, and we need to know what is the physiology of the patient who had already been transplanted with a solid organ, and what are the drugs what are the complications, what are the drugs they use, and everything about whatever they are using, it will reflect on anesthesia. Because as you know, for any patient, anesthesia is a added stress. So we need to go for anesthesia. For that reason, anesthesia and surgery are an added stress. So we need to know everything about the immunocompromised patient who is already transplanted with a solid organ, for to understand the complications and the precautions we need to take before going for a non-transplant surgery in a transplanted patient. So this topic is divided into 6 major headings. One is introduction, 2 is immunosuppression, 3 is preoperative care, 4 is anesthesia in toto, and specific patients and specific care in specific transplanted patients, and special cases in transplanted patients. So coming to introduction, as you can see, the number of solid organ transplants performed worldwide are ever increasing. For that reason, for that cause, in India also the rate of solid organ transplants are increasing, and these solid organ transplants are increasing because of the improved survival rates and the result of well-established surgical techniques and effective immunosuppressive therapy in the recent past. And increase in number of patients who present with either elective or emergency surgeries for a non-transplant surgery are also increasing. So as you can see in the bottom, all these are the solid organs that are transplanted to a that are transplanted. That includes pancreas, kidney, large bowel or small bowel, and eye, heart, bone marrow, lungs, and liver. So the common surgical procedures in a for a transplanted patients for a non-transplant surgeries are laparotomy for small bowel resection, hip arthroplasty, lymph node biopsy and excision, native nephrectomy in kidney transplant patients, bronchoscopy in lung recipients, biliary tract interventions for liver recipients, and abscess drainage.
సోడియం మీద డౌన్ అయిందే కానీ తెలిసింది సోడియం పెట్టిస్తారు కానీ
I'm muting everybody. So coming to the perioperative anesthetic management in majority recipients is similar to the standard practice of for any patient. The essential considerations are divided into two. One is transplant related and one is procedure related. The transplant related concerns are problems with allograft denervation, the adverse effects of immunosuppression, the interaction with anesthetic drugs, the risk of infection, potential for organ resection. The procedure related are immune competence alteration, stress of surgery, acute illness, and disruption of the regimen by inexperienced providers. So coming to the immunosuppression, in immunosuppression there are 6 side headings, which includes induction, maintenance, current trends, protocols, side effects, and drug interactions. So induction, what is induction? So induction of immunosuppression begins immediately before the organ transplantations, which includes monoclonal antibodies. Majority of the kidney, pancreas, and intestine recipients will receive monoclonal antibodies, and less than 50% of thoracic organ recipients will receive monoclonal antibodies, and liver recipients are very less uncommon to receive monoclonal antibodies. Then maintenance. How will you maintain? One drug from each group we will keep for the transplanted patients of these classes. One is calcineurin inhibitors, which includes azathioprine and antimetabolites, which include tacrolimus and steroids, which include prednisolone. Coming to the maps, the only thing we use regularly is Besliximab. So the azathioprine and cyclosporine and prednisolone, as I said, so these are, cyclosporine is now replaced by tacrolimus, azathioprine is replaced by mycophenolate mofetil, and prednisolone, almost steroid, is not given to many of the patients. These are the current trends which have been followed for almost all the solid organ transplanted patients. So what are the protocols? Most of the commonly used immunosuppressants have a narrow therapeutic index. So they display significant variability in blood concentrations between individuals with the same dose also. So subtherapeutic levels increases the risk of resection, and the supratherapeutic levels can lead to infection and drug specific, subtherapeutic levels will increase the risk of rejection, and supratherapeutic levels can lead to infection and drug specific side effects. So treatments for acute rejection continue to include high dose of corticosteroids and antibody therapies. So these are the protocols we do follow these days. So coming to individual drug classes and what are the drugs we are using. So the corticosteroids, we use prednisolone and methylprednisolone, and for calcineurin inhibitors we are using tacrolimus and cyclosporine A, and antimetabolites we are using azathioprine, cyclophosphamide, mycophenolate mofetil, and mycophenolate sodium. For polyclonal antibodies we are using ATG, and which can be rabbit derived or equine derived, and NRATG, and NR80S serum, only it's not globulin, it's serum, and anti-lymphocyte globulin also. So coming to anti-CD3 monoclonal antibodies, which include muronimab, which is CD3 monoclonal antibody, anti-CD52 monoclonal antibodies, which includes alemtuzumab, anti-IL-2 receptor monoclonal antibodies, which these are commonly used. We are using besliximab, but we can also use daclizumab, and TOR inhibitors such as rapamycin inhibitors. These are sirolimus. This is sirolimus. Sirolimus is the only drug, is the TOR inhibitor. And coming to the side effects of immunosuppressions, there will be lowered seizure threshold, diabetes, hypertension, hypoproteinemia, decreased glomerular filtration, hyperkalemia, hypomagnesemia, increased risk of infection, pancytopenia, osteoporosis, and poor wound healing. So what are the side effects of individual drugs? As you can see with cyclosporine A, you will have hypertension, you will have diabetes, you will have neurotoxicity, you will have renal insufficiency. Same with tacrolimus, but the only thing is renal insufficiency is more with tacrolimus compared to cyclosporine A, and diabetes is more in tacrolimus compared to cyclosporine A, but the risk of hypertension is less with the tacrolimus and compared to hypertension, when compared to cyclosporine A. Coming to azathioprine, it causes anemia and leukopenia, sometimes pancytopenia also. Coming to steroids, as you know, steroids increases the blood sugars. Steroids can cause hypertension, and steroids can cause neurotoxicity. And coming to mycophenolate mofetil, it can cause leukopenia, anemia, and thrombocytopenia, which include, as you can see, it's a pancytopenia picture. So coming to ADG, it can cause leukopenia, it can cause anaphylaxis because it is a serum derived thing. So it can cause fever also. Coming to OKT3, these include, the side effects include leukopenia, anaphylaxis, and fever because it's also serum derived. So coming to drug interactions, almost 3 to 5% of adverse drug reactions are due to drug interactions. So the reactions can be among two immunosuppressants or between an immunosuppressant and another drug. So during anesthesia, we provide, as we know, we provide a lot of drugs to maintain a balanced anesthesia. So this can potentially endanger the patient in the perioperative period. So we need to know the pharmacokinetic and the pharmacodynamic interactions that can occur between these drugs. Because most of these things, most of these immunosuppressant drugs are either cytochrome P450 inducers or inhibitors. So we need to know each and every drug that we are using and what is the immunosuppressant drug and what is its effects on the body. Now we can see here the drug interactions in the between the immunosuppressants and the drug classes that we use commonly during surgery. So coming to benzodiazepines, the adverse effects is all the immunosuppressants can increase the levels of benzodiazepines. So antibiotics will have the opposite effect. They increase the levels of cyclosporine A and tacrolimus. They increases the immunosuppressants level. So antimicrobials, they also decreases the cyclosporine A and TAC levels. And antimalarials increases the cyclosporine A and TAC levels. So antifungal increases the cyclosporine A and TAC levels. And renal dysfunction can occur. Antiretroviral drugs, they increases the cyclosporine A and TAC levels. Cardiovascular drugs increases the cyclosporine A and TAC levels, and it can also cause QT prolongation by amiodarone and quinidine. So particularly amiodarone and quinidine are to be used very carefully in these patients. Coming to statins, the immunosuppressant will increase the statin concentration. Anticoagulant concentration will be increased by the immunosuppressants. So oral hypoglycemics, they increase the cyclosporine A level if at all they are using. So coming to gastrointestinal drugs, which includes PPIs and also the gut stimulants also. Gut stimulants, they increases the cyclosporine A and TAC levels and also cause renal dysfunction. And QT prolongation is seen with octreotide, which is a somatostatin analog. When it is used particularly with tacrolimus, okay. Then analgesics. Coming to analgesics, NSAIDs, they increases the cyclosporine A and TAC levels and also increases the pimozide levels. Coming to the hormones, which are particularly used are estrogen and testosterone, they increase the cyclosporine A and TAC levels. Others, which include bosentan, carbamazepine, which has phenytoin, these are anti-epileptics, phenobarbital, octreotide, they decrease the cyclosporine A and TAC levels. As you can see, in particularly, octreotide will increase the TAC level when it used with tacrolimus and also causes QT prolongation. So preoperative care. In the preoperative care, we need to assess the graft function. A successful transplant abolishes the symptoms and replaces the functions of the failed organ. So persistent abnormalities from the underlying or pre-existing illness that may have already caused the organ failure or chronic physiological abnormalities, we are not, they are not modified by the transplant. So whatever the damage has been done to the body already, which will not be repaired, but the function of the organ will be good. So the function of the organ is good. So there is no further escalation of the already deranged physiology. So the preoperative evaluation includes the graft function, signs of resection, presence of infection, function of other organs, and functional status. So graft resection. Allograft resection may occur at any point of time during the post-transplant period if immunosuppressants are discontinued. The chronic resection is the most significant medical obstacle for a long-term morbidity-free allograft survival. So most common cause of mortality is the chronic resection. So the incidence increases with time. At 5 years, the chronic resection of liver is 60%, 10%, and for the lung, it is 60%. So the mortality is high if the resection remains untreated before surgery or procedure. So it needs to be urgently treated with increased immunosuppression. So coming to the preoperative assessment, we need to assess the comorbidities also. Most of the transplant patients will suffer from diabetes, hypertension, epilepsy, renal dysfunction, bone marrow suppression, lymphoproliferative disorders, adrenal insufficiency, hepatobiliary disorders, pancreatic disorders, and acid peptic disease, which includes upper GI bleed. So the preoperative assessment of infections, they are at risk of infections. It can be viral, bacterial, fungal, or protozoal. So it increases the morbidity and mortality. We need to rule out any kind of infection by either by laboratory or by radiological, because by doing a CT or by microbiology. It's an important point that immunosuppressed patients may not present with the typical signs and symptoms of infection. So we need to keep it in mind that there may not be a fever, there might not be any symptom that the patient is having because of the immunosuppression, but we still need to rule out any infection. So coming to the preoperative assessment and control of infection. The antimicrobial coverage needs to be expanded to include atypical and opportunistic organisms because these patients are immunocompromised. So the prophylaxis with broad-spectrum antibiotic 1 hour before the surgical incision is a must in this patient. Coming to what are the antibiotic prophylaxis we need to follow for a particular surgery. For cardiothoracic surgery, it is cefazolin, cefuroxime, and cefamandole. If the patient is having a beta-lactam allergy for cephalosporin, then we can include vancomycin or clindamycin. For vascular surgery, it is cefazolin or cefuroxime. And if the patient is having beta-lactam allergy, we have to go with vancomycin with or without gentamicin or clindamycin. So coming to colon surgery, it is oral and parenteral. If it is oral, neomycin plus erythromycin base antibiotic needs to be given, or neomycin plus metronidazole. For parenteral, it is cefoxitin or cefotitan or cefazolin plus metronidazole. For hip and knee arthroplasty, it is cefazolin and cefuroxime. If the patient is having a beta-lactam allergy, we have to go with vancomycin or gentamicin. Vancomycin with or without gentamicin or clindamycin, as I earlier said, this is a protocol. So vaginal or abdominal hysterectomy, we need to go for cefazolin, cefotitan, or cefoxitin or cefuroxime. So stress ulcer prophylaxis is a must in these patients, because these patients will be on steroids and immunosuppressant. There will be these are more prone for stress ulcers, as surgical stress and anesthesia stress is also included in this. On top of it, these are also included. So the causes of surgical stress, corticosteroids and mycophenolate mofetil. It's a must. So the venous thromboembolism prophylaxis, these patients are at high risk of venous thromboembolism prophylaxis. There are no clear guidelines what to give and what not to give. We need to evaluate the patients according to the patient, whatever the solid organ is transplanted, and according to the patient's PTINR and platelet function, everything, we need to tailor our treatment for venous thromboembolism. So coming to the functional status. So all transplant or post-transplant patients will not have that good functional status, because as I said, whatever the organ damage has been done before this transplant has already been done. It is not recovered. So there should be a must coordination between the anesthesiologist and the surgeon, and the communication with the transplantation team also, because they know better than the anesthesiologist who is doing the surgery now. They are having the record and they are maintaining the record. They know the baseline level of the patient before transplant, and they have to evaluate the graft. They will recent graft evaluation and functional data is also will be with them, and the medical history in detail is also will be with the transplantation team. So we need to coordinate between the transplantation team and the surgeon and the anesthesiologist, and we need to very vigilant regarding the whatever is happening with the patient after the transplantation. So what are the red flags of the functional status? These include weight gain, edema, dyspnea, sweats, malaise, fever, rashes, abdominal pain, abnormal breath sounds, changes in stools, and changes in urine output. These are not particular to any patient. These are seen with patients. Some of them are generally seen with all the patients which have going for having a decreased functional status, and some of them are organ specific. Particularly abdominal pain will be seen with liver patients, change in UOP is seen with, and kidney patients. Abnormal breath sounds may be seen with lung patients, and sweats and malaise, sweats and dyspnea are seen with lung patients or heart patients. So these are not specific for everybody. These are generalized symptoms which are seen in every patient. We need to segregate according to the transplanted organ. So coming to the investigations, what are the all these investigations are must in every patient who underwent transplant. So the laboratory parameters are complete blood counts. This is to rule out the bone marrow suppression, and electrolytes, renal function tests, liver function tests, coagulation profile, biomarkers, particularly brain natriuretic peptide, and in case of post heart transplant, chest radiograph, electrocardiogram, and echocardiography. So coming to the miscellaneous thing is depending upon the type of surgery and the transplanted organ. For that is coronary angle heart transplant patient, rescue in a heart transplant patient, spirometry in a lung transplant patient, or a biopsy in a liver transplant patient, or a kidney transplant patient. So coming to the cardiovascular evaluation, cardiovascular disease is a major cause of mortality and morbidity. So we need to compare the old records with the present records, and we have formulated the therapy and anesthesia. So what are the unexpected abnormal findings? Unexpected abnormal findings can be physical. The patient is having fever or something, or the patient is so weak that he cannot undergo surgery, or laboratory, or any suspicion of infection, or any suspicion of rejection, any suspicion of or a frank rejection, a frank infection also. If any abnormal findings are seen in these patients, we need to postpone the case. We can't continue with the case. We can't continue with the surgery and anesthesia, because it all these conditions will increase the morbidity and mortality. Amma silent ga undandi. Coming to the preoperative assessment. Preoperative assessment, steroids. There is no need for additional steroid supplementations, but if we need to start them if they are recently withdrawn from the therapy. So glycemic control, we need to have a close monitoring on the glycemic control. Immunosuppression will be daily monitored, daily blood levels of particularly tacrolimus need to be seen, and alteration of dose is not required if route is not changed. So oral cyclosporin can be given 4 to 6 hours prior to surgery. So coming to the anesthesia considerations, there is no ideal anesthetic. There is no ideal anesthetic plan. We can give any kind of anesthesia. It can be GA, it can be a balanced anesthesia, it can be a volatile inhalation mounted anesthesia, and we can go TIVA also. We can give regional. We can give neuraxial or peripheral nerve blocks. So what is the pre-medication? Standard pre-medication is used, what we are giving regularly. Dose adjustment is done for some drugs, particularly benzodiazepines. So coming to the monitoring, standard ASA monitoring, invasive monitoring depending upon the patient comorbidities and hemodynamic stability and expertise of the anesthesia provider. Strict asepsis is needed in these patients. So coming to the airway management, major concerns are most of these patients are diabetic. Either it can be a pre-existing diabetes or a post-transplant immunosuppression induced diabetes. These patients are diabetic. That can cause that can lead to difficult airway. Lymphoproliferative disorders can cause airway obstruction, gingival hyperplasia, gastropathy. Gastropathy can lead to aspiration. So we need to monitor the gastric emptying time, and we might need to increase the we need to individually tailor the post nilper mouth nilper oral guidelines also for individual patients. We need to assess individually and give for NBM instruction before giving NBM instructions as a standard procedure for 6 hours. And coming to the airway management, intubation oral is preferred. We can give supraglottic airway, or we can use for one thing we need to know is if in a heart transplant patients we cannot see any reflexes coming from heart because it is vaguely denervated. So we can't see any reflex, any increase in the heart rate or any increase in the BP in a post-heart transplant patient. That we need to keep in mind. No hyperventilation should be done because it can induce seizures. So extubation, we need to follow the ERAS protocols, and it prevents hospital-acquired pneumonia and ventilator acquired pneumonia also. So coming to the general anesthesia, all intravenous anesthetics can be used, but we need to see the hemodynamic status, cardiovascular side effects of individual drugs, and the pharmacokinetics of the individual drugs, and the drug interactions with the immunosuppressants. And coming to the benzodiazepines and barbiturates, as I already told, that you need to have a dose adjustment, particularly in hepatic impairment and renal impairment. And
about these switch drugs and what to do, Shekhar?
sir,
Because that anesthetic considerations, previous slide, no? Okay, right. Okay, fine. Right. I'm just looking for this explanation. That's all.
yeah. So intravenous anesthetics, propofol, there is no dose adjustment is necessary. The only concern is cardiac instability, as we know. Etomidate, no dose adjustment is necessary. The only consideration is only concern is the adrenocortical suppression. Ketamine, dose adjustment is needed because it can cause myoclonus or seizures. It can provoke seizures. So we need to adjust the ketamine dose. And inhalation, coming to inhalation anesthetics, halothane should not be used. Halothane is obsolete these days in any ways. And because it's hepatotoxicity and direct cardiac depression. And nitrous oxide is also having problems in these patients because it can cause bone marrow suppression and it alters the immunological response also. But other than that, we can use sevoflurane, we can use isoflurane, and we can use desflurane also. So coming to the opioids, fentanyl is suitable because it's short-acting and it's safe. So fentanyl can be used, remifentanil if available, we can use without any side effects. Morphine also we can use, but we need to adjust the dose a bit. Codeine, oxycodone, everything can be used, but tramadol we cannot use because it can cause renal failure, it can cause CNS depression, it can cause respiratory depression. Transdermal buprenorphine and methadone can be used without any dose adjustment. So coming to the neuromuscular blockers, we need to go for we have to decide which neuromuscular blocker should we use depending on the length of the surgery and the underlying neuromuscular disorders. So, and any history of malignant hyperthermia, particularly when we use succinylcholine. So, non-depolarizing drugs, we can use mivacurium, etracurium, cisatracurium, ecronium, pancuronium, and rocuronium. Though no dose adjustment is necessary unless there is no renal dysfunction or hepatic dysfunction. Succinylcholine, we can use it in RSI. The only problem is if the patient is having muscular dystrophy or malignant hyperthermia or hyperkalemia, we cannot use. That's a universal protocol we don't use in these patients. Coming to reversal, anticholinergic drugs, most of these drugs are eliminated through the kidneys. So in renal failure, we need to be more careful before giving neostigmine. And in heart transplant patients, we need to be careful because it can cause direct cardiac depression and it can cause bradycardia. Coming to Sugammadex can be used, but the data is very limited. And coming to the regional and neuraxial anesthesia, decision is based on individual basis, and risk and benefit analysis should be made before going for planning for any kind of anesthesia, particularly in neuraxial anesthesia. So advantages are superior analgesia, reduced pulmonary complication, and decreased graft occlusion. Because neuraxial anesthesia, general anesthesia is associated with the cooling of blood and it can cause it is a prothrombotic phenomenon. General anesthesia is a prothrombotic. Any general anesthesia can induce thrombosis. So it's not like with neuraxial anesthesia. Bupivacaine can be used, and levobupivacaine or ropivacaine, anything can be used. The only problem is hypertension. We need to preload the patient depending upon his cardiovascular status and the renal function. And we need to use adrenergic. If at all needed, we need to use adrenergic drugs. So before going for neuraxial anesthesia, we need to see any sort of bleeding tendencies, such as particularly complete blood counts and bone marrow depression. Is there any bone marrow depression is there? We need to see. And coagulation tests, which includes, these are normally we do these parameters in all the patients underwent transplant. So PT, INR, APTT, and fibrinogen levels. And peripheral nerve blocks, they are always indicated whenever you can give a peripheral nerve block. It's useful and it's effective because it has a long duration of action when you add adjuvants, and it can be easily done with ultrasound guidance. So coming to the post-operative management, patient can be, we need to follow the early extubation and early ambulation ERAS protocols, and we need to keep the patient in an ICU or a post-anesthesia care unit depending upon the patient hemodynamics and the patient functional status post-surgery. And the ICU, post-operative management is tailored according to the case and the patient. There is no particular clinical guidelines regarding post-operative care. So we need to decrease the delirium incidence. We need to decrease the sedation. By minimizing the sedation, we can decrease the delirium incidence. We need to go for early extubation, early ambulation, physical rehabilitation when needed, and analgesia, particularly with paracetamol, patient-controlled analgesia, and patient-controlled epidural analgesia. So no NSAIDs at any cost. So because they can cause gastrointestinal hemorrhage, nephrotoxicity, hepatic dysfunction, and increases the level of cyclosporine. Specific patients and care. So heart transplant patients, they lack neural regulating mechanisms on the heart. There is no sensory innervation, there is no sympathetic innervation, there is no parasympathetic innervation, and there is a higher resting. They kept it a higher resting rate. There will be 2 P waves, one coming from the original sinus node and one coming from the transplanted sinus node, and higher risk of developing atrial flutter and fibrillation because of the discordant sinus stimulation. And preload they are preload dependent because there is no innervation. That's why they are preload dependent. We have to maintain systolic blood pressure. We need to prevent hypovolemia. They will have a low cardiac index, low normal cardiac index, and they respond to direct acting drugs such as adrenaline and noradrenaline. Atropine has no role because it is a parasympatholitic. So there is no innervation, it will not act. So isoprene, dobutamine, and adrenaline can be used because isoprene directly acts on the node. So levosimendan and milrinone, these increases the contractility with no increase in the myocardial oxygen demand. That's why these drugs are preferred whenever we need to use. And these are arterial and venous dilators. They decrease the afterflow. The signs of resection in a heart transplant patients are myocardial dysfunction, accelerated coronary atherosclerosis, severe dysrhythmias, silent MI. All heart transplant patients are given GA only. So invasive monitoring is done with all the lines, including CVP and arterial invasive blood pressure monitoring, and we need to keep an eye on the heart function during the surgery with TE. So coming to lung transplant patients, they lack cough reflex. They are unable to clear the secretions in sedation. So silent aspirations can occur in these patients. Regional anesthesia is preferred in these patients. So preoperative spirometry is necessary. Preoperative X-ray, if needed, we need to do an HRCT of these patients before preoperatively only. Crystalloids should be used very judiciously because the altered lymphatic drainage in these patients in the lungs can cause interstitial edema. So invasive monitoring is a must in these patients also. So coming to the post-kidney transplant patients, they are at a high incidence of serious disorders because already because of the increased afterload and increased preload, their cardiovascular there will be already established cardiovascular dysfunction in these patients. The cause of mortality with cardiovascular disorders is 32% in these patients. Diabetic association we need to look out for. And any if the patient is diabetic, then he's developing a kidney, renal dysfunction, then we need to look at the blood sugars also. And prolonged drug and excretion can be seen in these patients because of low GFR and low effective plasma flow. So the signs of dissections include proteinuria, azotemia, and hypertension. We need to prevent the graft failure. We need to use the fluids very judiciously. We need to very cautiously use the diuretics, avoid the neurotoxic drugs. And the prolonged action of neuromuscular blockers is also to be kept in mind before giving the neuromuscular blockers. Coming to the liver transplant patients, all ailments begins to improve after a liver transplant. Immediately, we have to maintain the hematocrit. We have to prevent the hepatic arterial thrombosis. All types of anesthesia can be given. Neuromuscular blockade is preferred, and we need to evaluate a CBC and coagulation profile in these patients before going for surgery. Coming to pancreas, it is a single organ transplant. It can be a single organ transplant, or it can be used with synchronous pancreatic and kidney transplant. So this SPKT is done on only uremic diabetes. So long-standing diabetes can cause coronary artery disease. There is an increased risk of aspiration because of gastropathy, because of diabetes, airway compromise because of the lymphoproliferative disorders, and diabetes. We need to keep an eye on the difficult airway, signs of resection, increased amylase levels, and glucose monitoring. Coming to intestine. So types are isolated intestinal transplant or transplantation of combined intestine, or liver graft with multivisual transplantation. These three can be done in a liver intestinal transplantation. So intestinal transplant has the highest resection rate. It can cause enteritis, it can cause ischemia of the transplant organ, there can be bacterial translocation, there can be diarrhea, there can be loss of weight. Judicious fluid management should be done in these patients because of the high rates of resection and prolonged TPN. Prolonged TPN might lead to thrombotic complications in these patients. Coming to special cases, trauma. Chronic immunosuppressions can lead to osteoporosis. Rest of the management doesn't differ much in trauma patients of anything, because I already discussed in individual what we need to see in individual solid organ transplant patients. So judicious replacements of blood products, leukodepleted packet cell RBCs needs to be transfuted, irradiated blood products need to be transfused, and the patients are advised for a better self-care to prevent trauma. So pregnancy. This is a unique challenge to the team, which includes anesthesiologist, gynecologist, and the transplant team. So ideal time to plan a pregnancy is after 2 years of transplant. So there is increased risk of comorbidities and obstetric complications in this patient. There is increased risk of eclampsia. There is increased risk of gestational hypertension. There is increased risk of gestational diabetes. The physiological changes, if the pregnancy can affect the graft function, the maternal and the fetal side effects of the immunosuppressive agents can be there. In maternal, coming to the maternal side effects, there can be nephrotoxicity, hepatotoxicity, diabetes, hypertension. Coming to the fetal complications, these can, all the drugs which we give in immunosuppressions will cross the placenta. So as of now, there is no congenital abnormalities are noted, but they will affect the immune system of the fetus. It can lead to low birth weight, premature labor. The plan of anesthesia is decided according to the case-to-case basis. The abdominalgesia is preferred if the patient's coagulation profile is normal. Opioids can be given. No anesthetics, as I said, and thromboprophylaxis depending upon the patient's condition. Coming to laparoscopic surgeries are advantageous compared to open surgeries, because they are associated with short hospital stay and early ambulation, and the patient can be ambulated early, and the patient can be sent home, and we can continue his treatment and daily activities as soon as possible after the surgery. So outpatient procedures can be done in these patients, but with strict asepsis. The plan of anesthesia is tailored according to the patient. They can undergo, they can be done under TIVA or MEC. So these are my references. Thank you for the patient hearing, and the topic is open for discussion now.
Nice class, Shekhar, and very good appropriate caricatures for each slide. You must have spent a lot of time to have a proper correct caricatures. And definitely for a post, like, previously in a PG time, our interest was cardiac case for non-cardiac surgeries was very, very important, interesting. Now it is a transplant case for non-transplant surgeries has become more point of care at this point of time. I think because of improvement in the point of care system, right?
Yes. Any questions from all any of the audience? Have any questions?
Good morning, Shekhar.
Good morning, sir.
What are the types of rejection, and what is the name of a granulocyte stimulating factor and dose?
What is that, sir? Granulocyte stimulating
factor. Trade name. Injection is available, and the dose.
Filgastrin, sir.
Huh?
Filgastrin.
Neuprogen, 300 micrograms. OD.
Okay. Filgastrin is also a granulocyte stimulating factor, sir.
But I don't know. This is usually used in our institute.
Okay.
No, Raman Prasad garu, ఈ ఫిల్గాస్ట్రిన్ నిప్రోజన్ రెండు ఒకటే కదా?
తెలియదు సార్ నాకు.
I don't know, sir. That's why.
ఫిల్గాస్ట్రిన్ అయితే జిఎంసి చేస్తారు సార్, ఆ రెండో తెలియదు నాకు.
రెండు ఒకటే శ్రీకాంత్.
రెండు ఒకటే అయి ఉండాలి సార్.
అదే తెలియదు సార్. I don't know, but I know filgastrins are might be known that. So
Popular stand. Effectively, how long is
there? Filgastrin is a drug name, Neupogen is a trade name.
Okay, sir.
Okay. Like in COVID, do you have any specific period like post any transplant? We have to defer elective surgeries.
No. No. The thing is, we cannot defer these patients because, as I said, that also on the third day of a post-renal transplant, I need to do a emergency surgery for that patient because the urethra was ruptured while keeping the Foley's, and the patient is not having any urine because
not about emergency.
Foley's went into the fast track.
Okay, and elective cases I'm asking.
Elective cases we can these patients come for elective cases. I don't think come for elective cases that immediately. We don't have that information as of now, but for emergencies there is no delay. For elective they can wait up to, as I said, for pregnancy is an elective thing, so they can wait up to 2 years before getting pregnant after transplant.
Yeah, and pregnancy can be prevented, but like hernia, how long can we wait?
That depends upon that's the discussion that needs to be done by the team at that point, depending upon. I think so, because we all have a limited experience with these patients.
Not only that, like how we send the patients to the cardiologist, we should send to the transplant surgeon for the post fitness, right?
As I said, there should be a close communication between the transplant team, between the surgeon, between the anesthesiologist, So that what are the tests we need to do, how to assess the graft function, and how to if the graft function is not effective, is not good, or there is signs of rejection. There are signs of rejection which are seen. Then how much dose needs to be increased. So these are all the things we need to discuss as a team on an individual basis for each case.
But in case of post CABG and all, we don't need, because we know entire protocols what to be checked for,
Yes,
and we don't have to go back to surgery
those
at
are-
all.
That's a well-established system. But this coming to non-transplant, it is not that well-established. Guidelines are not there yet. Maybe in the recent coming future,
What moderator
have
says?
certain guidelines regarding these surgeries.
What is the moderator's comment or senior's comment?
Thank you, Shekhar. You have explained very well. So only we have to remember the first one is physiology of the patient, and the second is drug interactions. So immunosuppressives, drugs related to anesthesia, anesthesia drugs related to immunosuppressant, and third is investigations. Fourth is complications. What complications are come? So always remember rejection and infection. And fifth one is communicate with the transplant team and present who are doing surgery, surgeon and anesthetist. You have to talk, and accordingly we have to plan. And sixth one is always maintain the TAC levels. If less than 10 is okay, but if more than 10 TAC level, patient will go to nephrotoxicity.
This is cheating, Anuradha.
దేనికి సార్?
Remember only 3 things అని చెప్పి 6 things చెప్తే ఎట్లా?
అలా వచ్చేసింది ఫ్లోలో. అంటే 3 అంటే ఫిజియాలజీ, కాంప్లికేషన్స్ అండ్ డ్రగ్ ఇంటరాక్షన్స్. 3 సార్.
ఏంటి రాణి మేడం, మీ పోస్ట్ క్రిటికల్ కేర్ ఎక్స్పీరియన్స్ ఆఫ్ లివర్ ట్రాన్స్ప్లాంట్ చెప్పండి. ఏం శేఖర్ లేరా మేడం?
మేడం ఉన్నారు సార్.
Hello, sir.
ఏం లేదు మేడం, వాట్ ఈస్ ఇట్ యువర్ సజెషన్? బికాజ్
Shekhar, nice class.
Thank you, madam.
Shekhar,
Thank you, madam.
yeah, regarding drug interactions, you said, no, like, basically, like what all you said is, it's between drug, as you said, inducers and inhibitors. So the way the actions are increased, decrease means, like most of the immunosuppressants, they are drug inhibitors. I understood, because the other drug actions are increased. At the same time, most of the antibiotics, they are drug inhibitors. So the action of immunosuppressants are increased. So that's how, like, everybody should remember. So will this, is this an inducer or is this an inhibitor? So the action of other drug is increased means what you're giving is an inhibitor. The action of other drug is reduced means you are giving inducer. So with inducers, the action of other drug is reduced. That means inducers will metabolize the drug very quickly. So action is not long enough or dose is not good enough. So that's how we should remember. So all the students should remember pharmacokinetics, pharmacodynamics, and drug metabolism are the inducers or inhibitors. If you remember that, like when you're giving anesthesia or when you're giving a particular drug, like all of us know, phenytoin, barbiturates, all these are drug inducers. And cimetidine, rifampicin, all these are inhibitors. So there's a big list of inducers and inhibitors. So all those you have to remember. So, you know, like now, when Shekhar said about this, I understood antibiotics are inhibitors, and the same way immunosuppressants are also enzyme inhibitors. So when you're giving this antibiotics, your immunosuppression action is increasing. When you're giving immunosuppressants, the other drugs what you're using for other things, they are prolonged. That means your immunosuppressants or inhibitors as well. So mainly, as Anuradha said, it's all drug interactions, induction, drug inhibition, and the volume of distribution in the patient, and how long the three compartment model, all these physiology, pharmacokinetics, pharmacodynamics is very important. If you know all that, you can play around the physiology when you're doing any case with any anesthesia. And coming to elective emergency, I think most of us, we don't do elective surgeries soon after transplant. Anyway, it comes to emergency is a clear cut, but there are some cases like semi-emergencies, recurrent obstructive hernias, it keep coming going, so that you may have to do sometime soon. And unexpected, like you get a CA somewhere after doing the transplant within few months, then you may have to operate. So you can't wait for too long. Such cases, we have to take all precautions and aseptic precautions and discuss with the transplant team and do whatever is required with minimal effect on the body physiology. That's all I can say. Thank you.
Shekhar, I have posted one book, Drug Interactions. I've not read it. It's a big book. So I think it might be having a lot of molecular level interactions, as well as particularly nutrient drug interactions, drug few interactions with the nutrients, not actually drug interactions. Drug interactions I'm searching for. If I get it, I'll do that. Thank you all. And as Madam
you.
was talking about an oncology patient after post surgery, most of the patients, when we are going for a transplant, I think we are supposed to do assessment of oncology also. Otherwise, the life expectancy may come down, or we may not supposed to do is transplant. I'm thinking so. Thank you all.
Shekhar, what is the role of prophylactic antifungal and prophylactic anticonvulsants in non-transplant surgery in a transplant patient?
Sir, as of now, there is, as far as my knowledge, there is no prophylaxis in these patients. We don't start prophylactically any antibiotic, but we need to rule out every infection before going for surgery.
He did not say antibiotic. He said the anti-epileptic and antifungal.
Yes, sir. What I'm saying is, either it is an antifungal or an antiviral or an antibacterial, we don't prophylactically start in these patients. We have to rule out every infection before going for surgery, because these patients will not manifest any infection symptoms or signs. So we need to go for a detailed evaluation of the blood cultures and or urine cultures, whatever we need to do, we have to do to rule out the infection, and then we have to appropriately start the treatment for that before going for surgery. But as of now, there is nothing like we'll go for prophylaxis other than the surgical prophylaxis that we are giving regularly in these patients. As I described, the individual cephalosporins, particularly cefuroxime and cefotetan.
No. He's not talking about antibiotic, Shekhar.
Sir, that's what, sir, I'm saying.
What I'm asking is, please, okay, one minute. See, what he's telling is prophylactic antifungals. Prophylactic means when you suspect something, or there is a fungal scoring system is there. You have scoring system for the patients whom you are supposed to start antifungals is written, and there's one chart is there. The pharmacy guys will give the charts also. So if you have that scoring system more than whichever is crossing more than 2 or 3, then you are supposed to start. When you start normal cases of antifungals, you just start with ciscananone. So do we give either fungins, anidrilla fungin or something, echinocandins, or what we give for this kind of transplant?
As far as there are no guidelines to start prophylactically antifungals, sir.
Oh, I think Shekhar, there are some guidelines for antifungals in immunosuppressants, post-transplant cases, and neutropenic patients, and all these cases when they develop or when you suspect sepsis. I think there is a role for antifungals, particularly if you think a immunosuppressed patient who developed perforation. It could be fungal infection, perforation, or lung fungus, or cerebral. Anything can happen. So you send for hyphae, and at the same time, I think they start echinocandins for all these suspected cases. But as you said, if it is for elective surgery pre-op, you don't have to, you rule out sepsis. But if there's any little suspicion, then they start prophylactic antifungal only for these particular cases, not in all other cases. I think there's there's a prophylactic antifungal, there's a topic and articles on this. Maybe we can check and see what all conditions we should give.
My point is also same, madam. You don't start the patient on antifungals if there is no fungal infection. If you suspect any fungal infection, then we can start. There is any suspicion of fungal infection, particularly aspergillosis in a post-lung transplant patients, we can start. Or if there is any fungal mucormycosis or something, anything that can start in an immunosuppressive patient, then we have to start antifungals, and we have to reduce the infection before going for surgery. That's what article says.
Not related to this topic, Shekhar. Can you just tell me what is the mortality or 5-year percent, 1 year survival rate in each transplant separately?
Sir, I don't have the data actually. What I know is the least survival rate is for intestine. And the maximum survival rate is for liver.
Okay. So what I understood, as for my knowledge, you need to correct me if I'm wrong. So lung, I don't know about intestine, but the lung transplant survival rate is around 40% in first 1 year, and at the long term it is 15%. And
yes,
if it is a heart transplant,
kept in the slide also.
Yeah.
The rejection rate at 5 years is 60% in lung.
Yeah.
And it is 10% in liver.
Yeah, and for heart, it is actually a little better than that, but still it is not more. In 5 years survival, it is only 20 to 40%. And
yes.
The most better one is presently is a kidney only. But the liver is also, it's having around 5 years survival rate of 60% and 1 year survival rate of 35%.
Liver is better survived, sir, compared to kidney.
That's what.
The rejection rate, you said the opposite, that's why.
Yeah, but the longevity of 5 years, rejection rate is okay. But the survival rate for kidney is little longer compared to liver.
No, sir, the survival rate is also for kidney only.
Okay. Less, sir?
I have seen post 15 years liver transplant patient.
Yeah. No, it's not that anecdotal. It's not the anecdotal. It's a total percentage. I don't know. We'll check that.
But the survival rates are better with liver only compared to kidney.
I think as per records, as per literature, kidney is the longest and then comes the liver. I think lowest is heart, I think. And intestine.
Madam, and then
have to check.
Sachinand sir is also here. He is also saying liver is the best, longest. Liver is having better survival rates.
Venul
sir.
80% 5 years survival.
Liver is 80% 5 years survival, he's saying.
True. I know.
And compared to adult and children, children liver is a more survival rate, sir.
ERC pains are patient. 2D cardiac transfer. Plus or minus transfer.
Thank you, Shekhar.
Thank you, sir.
2D cover చేసుకొని వచ్చారు.
Thank you, Shekhar. Thank you to all.
Thank you, madam. Thank you for patient hearing.